and how to better use community source data in outbreak responses through applying an integrated outbreak analytics approach or an IOA approach. So you might be thinking, what do we mean by community source data? And well, we're defining it quite simply. It's any data, qualitative or quantitative, collected from individuals at the community level. And I believe we were all on the same page here, but just to be sure, we're defining IOA. Is there feedback or is it just me? Oh, cool, thank you. Yeah, so just to make sure we're on the same page, we're defining IOA as bringing together all data sources. So for example, surveillance, programmatic, HIS, and community data. So this session today is the first in a two-part series on this topic. Today's call is going to focus on sharing and debating how best to use these data and outbreak responses through applying an IOA approach. And in the second call, the next one, March 4th, we'll continue the debate and discussion. And we want to work collaboratively on an output that will broadly give guidance on sort of what to do or not to do when using community source data and outbreak responses. Today, we're delighted to welcome modelers, epidemiologists, response leadership, and social scientists to share on what has worked and not worked in integrating community source data into outbreak decision-making and why. Social scientists will also speak to how they've been able to navigate some of these barriers for improved use of community source data. So I'm excited to welcome from the London School of Hygiene and Tropical Medicine, Sophie Meakin and John Edmunds. From MSF, John Johnson. From MSF Epicent, Aminata, who I believe, has Aminata joined yet? I think she'll be joining soon. Unfortunately, our Oxfam person, Raisa, had to pull out. There's a storm happening in the UK today, and she's having some disruption related to that. And from CDC, Henriette Bulambo. So I'd like to ask John Johnson from MSF to please open the floor. And just to say that I'm really sorry, but I will be quite strict with we've given everyone about a 3 to 4 minute time limit for presentations, because we really want to leave room for discussion and debate at the end. But I will give a 30-second warning. So over to you, John.
Okay, I'll be quick then. So nice to meet you all. I'm John Johnson with MSF France. I'm a vaccination advisor. Can you see my screen?
Yes, perfect, thank you.
Okay, so real quickly, just to talk about community source data in outbreak response. Obviously, MSF, we can't help but be an external actor. That's by default who we are. Wherever we work, we're coming in from the outside. And that affects the point of view that we have to the communities that we work with. We're not necessarily part of that community. So we have to make enormous assumptions about their needs, their motivations, and priorities. So as public health actors, most of the interventions that we carry out focus on, in an epidemic, interrupting transmission, reducing mortality and morbidity, using tools like isolation, vaccination, case management. These things are shown to work, but they're not necessarily what the community has asked for. And we're not necessarily using them in the design of this response. And the community is, by default, the driver of an epidemic. So interventions like vaccination, distribution, water, sanitation, hygiene, safe burial practices, etc., masking, social distancing, they work best when communities actively engage and participate. So this is where community source data can help us. It'll give us a better understanding of community needs, motivations, and priorities, and also can help us understand what interventions are going to work and which ones won't, and how better we can conceive the interventions that we have. So some very quick examples, kind of stupid and obvious, but places where we've seen low uptake of COVID vaccination, the first assumption is people are anti-vax or they're reticent. And a lot of times we get some information from the community and it shows that actually the site is not located in a convenient location, or it costs too much money to get there, or it's really just a question of they're worried about effects and they don't have access to paracetamol if they have a fever. And these are easy things to solve. Or in Ebola, for example, Ebola treatment center transfer or safe burials. A lot of times transfer was delayed from a managing clinic because the managing clinic didn't want to give up the patient for financial reasons. Well, that's easy to fix too. Or we were using opaque body bags early on, and we learned that people really just needed to be able to see the body. And so we were able to provide body bags later on with windows. So community information can actually give us quick and easy solutions. The limitations and challenges, this is, it's actually quite difficult to integrate all the information that we get into traditional operations. We can't completely change the way we act. And a lot of times it's a lot of information and we're not sure what to do with all of it. It may give us understanding to a problem with no easy solution. So, things like poverty or systemic problems, we can't necessarily change that. Rumors like COVID vaccines will kill you 2 years from now. Well, that's nice to know, but I don't know how we can convince someone otherwise. Or, things that could be worked on, but aren't necessarily simple in an epidemic. So the population prefers traditional healers because they're more personable and they have a personal relationship with them, or they're closer. And that's not necessarily simple, but it is something we can work on. Also, community data often tells us things we already know. We've heard about these things, but we haven't, systematized the collection of the feedback. But sometimes it confirms what we've gotten in anecdotal observations. And oftentimes, epidemics are quick. You don't have the time to set up these sort of interventions to collect information in a measles or cholera or meningitis outbreak because you're working on the order of 2-3 weeks. And that's it for me. I'll stop there. Thanks.
Thanks so much, John. That was great. And I believe we have Aminata with us. So over to you, Aminata, on community data and in epidemiology. Or maybe Simone is.
I think it's possible that she's dropped out.
I think she's dropped out. Okay.
Yeah.
I know she's having connection issues. So for now, why don't we move on to you, Sophie, if that's okay. Talk about community data and modeling.
Okay, great, thank you. I don't actually have any slides, so I'm just going to talk for a couple of minutes.
Of course.
Okay, yeah, so I'm a modeler at London School, did a PhD in maths, but I've worked a bit. I worked a bit for the WHO during the North Kivu Ebola outbreak, just to give a bit of context. So the way that modelling can obviously contribute to outbreak response is in a whole bunch of different ways. It might help to kind of inform about the state of the outbreak by estimating some parameters. We can make forecasts and potentially evaluate possible interventions that we're going to think about putting in place. So to kind of think about whether we can use community data for modelling, I think that it absolutely can be used. But in practice, it's obviously quite difficult, and so perhaps doesn't happen as often or as well as it could. So after talking to some colleagues about this, I think there were some kind of common themes about when this works well. So during the pandemic, the kind of use of community data has been most successful when it's measuring values clearly that relate to components of the transmission process, so can kind of feed directly into the model. So, and a good example of this is the COMICS social contact survey led by LSHTM, which collected data on age stratified social contact rates over time. And so this can be used in models to capture how contact changed with changes in restrictions and lockdowns. Obviously, it doesn't always go this smoothly, and I think there are quite a few challenges, which I'll just describe some of. So I think the first one is kind of this coordination between modelers and teams that collect the community data to make sure that data is being collected about topics that can either inform model development or their parameterization. And obviously, if there is poor communication between these teams and it's not well developed, then it's very optimistic to hope that this interaction is going to be sort of as fruitful as it can be. In kind of developing models and evaluating them, once kind of community data has been collected, we need to think about how this can translate into kind of structural changes in the model. And if we include kind of a behavioral component, can we parameterize these? Can we actually kind of meaningfully say, can we kind of attribute quantities to them that allows them to work? And I think it's also really important to think about whether including kind of behavioural factors actually can improve results. There might be some instances where including factors in the model in a bad way could actually give you worse results than not including them at all. And obviously all of model development takes a lot of time, which is another reason to have really well-established relationships with teams before and not just during outbreaks. Yeah, another big challenge, which I think has been faced during this and the West Africa Ebola outbreak, is how to translate some kind of socio-cultural kind of qualitative information into quantitative values in a meaningful way. And finally, is kind of like a operational aspect. So is data available and updated in real time and in a format that modelers can use? And I think this is especially true when informing parts of a model might change, parts of a model that might change over time, such as the contact data, or when making things like forecasts. Yeah, so that's all from me. Thank you.
Brilliant. Thanks so much, Sophie. I believe Aminata is not able to join us yet, so I suggest we move to Henriette to talk about, so give us an example of using community data. She's going to specifically speak to household surveys.
Okay, thank you. Okay, thank you for having me. Unfortunately, my camera is not working. I tried earlier in the morning and I couldn't make it work. So thank you for having me. My name is Henriette Bulambo and I'm a CDC health scientist. I'm going to share some work that I'm leading, which seeks to create high quality Ebola surveys in local African languages. One important step in doing this is to understand how existing survey questions are understood when translated to African languages. So our evaluation of Ebola survey questions arose out of our work assisting with several Ebola responses in DRC. The map shows that Congo has had many Ebola outbreaks since 1976. The dots show where Ebola outbreaks have occurred, with each color indicating a different Ebola strain. The development of vaccines and therapeutics has improved the outlook for quickly ending these outbreaks, but it has still been challenging to gain public support for controlling measures, partly because the response has not been aware of the needs and concerns of affected communities. At the end of the 2018 outbreak, we decided to create gap survey in 3 African languages for future use. So previous Cangrid, there are no cognitive interview have been conducted on Ebola gap surveys in local languages. The purpose of this work was to assess how Ebola survey questions are understood when translated from Western to local languages in Democratic Republic of Congo, and to summarize the most common type of questions problem in order to promote best practices in question design going forward. So Kinande, Kiswahili, and Lingala are spoken in areas where there have been frequent Ebola outbreaks in the Democratic Republic of Congo. Therefore, we established our CAP survey project in Beni, Goma, and Kinshasa. The map shows that these languages are spoken in Ebola-affected regions. In order to develop surveys in these languages that participants will understand, we use a cognitive interview process. We recruited more than 60 participants of different demographic and language groups, and we conducted in-depth interviews. Our cognitive interview process involved posing each interview questions, determining whether it was understood, and if not, understanding why. Problematic questions were revised and retested until surveys were fully understood. So this table shows demographic characteristic of 65 cognitive interview participants. So in the 2 survey instruments, we identified 71 questions with problematic wording. In addition to correcting the question with problematic wording, we also reviewed each one to identify what kind of issue was present for the question, and I grouped this issue into themes. This was done so that we could understand what kind of problem we see most often. In conclusion, the fact that nearly half of the question proved problematic shows the importance of performing cognitive testing of questions. The most common issue that we saw were some terms like Ebola response, contact tracing, didn't have local translation and were better understood in French. African language translation was sometimes too formal and not in everyday spoken language or in the local dialect. In some cases, the way we structure questions in French or English were unfamiliar and created confusion. Lastly, there were some terms like community, which really needed to be either clarified or rephrased to get at the intended questions. We had to really think about what we wanted to know, and then with the help of native speakers, select locally meaningful words and phrases. Example of specific problematic question of these leading themes are provided in the next few slides, but I won't cover them. This concludes the presentation. Thank you again for listening and for all who contributed for this work. We will now take a few moments for questions. Thank you.
Thank you so much, Henriette. I think before we move on to the question phase, we have, I'd like to give John Edmunds the floor, actually, and to just get his reflections and thoughts as well before we move on to a discussion and questions, if that's all right.
Sorry, I was muted. Sorry, I was just typing some. I was just typing my slides just as we were speaking, but I think they're about ready, so I'll flip over. If I can share my screen. Oh, well, you'll stop others from sharing. That's okay? I was going to say a couple of things really about.
Sorry, you should be able to share your screen, John.
Yeah, I'm doing it now.
Oh, perfect. There we go. Thank you.
Okay, yeah. So I was going to say just a couple of things. Trying to summarize some of the things that we've just heard and a couple of points I want to make myself. So I think there are really two routes whereby community source data are used in outbreak analytics. And the first is the sort of direct route. So that the data that are collected are of value in their own right and may be directly reported to decision makers, those on the ground making decisions about what to do in the outbreak. So these might be reports, either verbal reports or written reports. They could be of surveys and so on. And so we've just heard examples of those. They might be feeding back, as John Johnson said in the first of the little talks, feedback about community needs.
Why?
Sorry, someone's talking, but anyway, operational issues and so on. There may be simple indicators that could be incorporated on dashboards, and increasingly you'll see these happening. So some measure of community engagement or some sort of measure of that is often now incorporated on dashboards, and so. And I think we'll increasingly see this happening. And of course, there's many difficulties in that. We've just heard about it. In difficulties in actually getting the information that you think you're getting accurately back from participants in these sorts of surveys because of problems of translation, which are so obvious but are so often neglected. I think that was a really nice example that we just heard from there. Incredibly difficult to do properly, all these things take time, and time is what you frequently don't have in a lot of cases. And as John said at the beginning as well, some of these surveys or information might actually highlight problems that don't actually have an obvious or immediate solution, and so may not be. I mean, it's useful to know, but you may not be able to action the information or take action directly related to that information at the time. So that's the sort of direct route whereby these information feed into decisions, and that's the sort of straight into the decision makers, those who are running the outbreak response on the ground at the time. And then there's a second indirect route. Oh, and I should say about the first route is that the information that's collected can be qualitative or quantitative in nature. And then there's the indirect route, and that's through mathematical models where the information is collected, and the intention of it is then, or part of the use of that information is to go through a model, which are, of course, tools that are increasingly being used to guide outbreak response. And so, can those, so are you collecting data? And this is what Sophie was touching on, collecting data in order to directly or to inform models. And normally under those circumstances, that information would need to be quantitative in nature. And that in itself is difficult. Some of these notions are really not, some of these things are really not quantifiable in any easy manner. And of course it needs, again, if you're developing a model and using information, it needs time, it needs partnership, it needs this two-way relationship. Sophie was talking about that in terms of the relationships that might need to be there, might need to have been there in place before the outbreak in order for trust to be there. Another option, of course, is to bring the modeling closer to the outbreak, and this is something that Thibaut Jeanbar, I think, is on the call, has been trying to do over the last few years, and take and work actually in the community as best as possible, as close to the outbreak as possible, and do the analysis and indeed modeling there, which takes out some of the delays and sort of Chinese whispers perhaps. So those, I think, are the two main routes. I'd just like to, and of course, one of the big issues with the use of particularly social science or behavioral data in models, at least, is that some of the things that we would like to quantify are not terribly quantifiable, and we don't have good models of how a change in someone's, say, risk perception might change their behavior. So our models of human behavior are very poor, and so we can't really predict how people might change their behavior. One of the aspects of every epidemic really is that individuals do tend to change their behavior. Part of it is enforced or trying to be enforced as part of the public health response. You may be trying to get individuals to change their behavior, perhaps people who are infected at the time, or the whole community to change their behavior in some way. Or it may be in response to individuals' risk or something like that. And we don't know how they might respond to given information. We can't predict it very well. And I'll just show you a couple of examples. Oh, sorry, I forgot to put it on full screen, but I'll show you a couple of examples now, just from the data that we've been collecting from the COMIC survey, which has been collected here in the UK, but also elsewhere in Europe across the course of the COVID pandemic. So this is this is a figure from Amy Gimmer's work, which should come out. It's already out in medRxiv, and there's the reference, and it should come out in PLOS Medicine sometime soon. So this is data collected over the first year of the pandemic in the UK, and these are individuals who the survey, we ask about 3,000 people every week in order to report on their contacts, people who they met, and details of those people. So did the contacts occur in the home, and those people who they met, what was their age, and were they household members or non-household members, and so on and so forth. And you can see this is just mean numbers of contacts reported over time. The grey shaded areas are periods of time when lockdowns were in place in the UK. So we've had 3 national lockdowns, and they're shaded there. And in each panel, you can see the upper panel, the upper of the 2 graphs are younger adults aged 18 to 59, and the lower panel is older adults aged over 60. And this just shows you the 4 different quadrants there. These are some measure of risk or risk perception. So the top left is I'm likely to catch coronavirus, and you can see that those who said yes tended, agreed with that statement, tended actually to make higher numbers of contacts than those who said no. The top right is I'm worried I might spread coronavirus to someone else, and that didn't seem to make much difference to people's recorded contacts, actually the contacts that they make. So if they were worried or not didn't really make much difference. Coronavirus could be a serious illness for me, and you can see there's some differences. So those that think that coronavirus could be a serious illness for them, which is the red lines, there are some differences, particularly in the older adults. And so those who think that it won't be a serious illness to them, particularly older adults, tended to make higher numbers of contacts over time. And then finally, this is actually their clinical risk. Are they in a clinical risk factor? And again, that made some difference. So there are some differences you can see on the lower right-hand panel there. These are people who are those who are in high risks, older adults who are high risk. That's the blue line there. Do tend to make fewer contacts over time, but the differences are not large. So what's really affecting this is it are other things, government intervention. I'll show you that even more clearly on the next slide. This looks at the same survey, but looking at mask wearing. So this is mask wearing in England over the course of the whole of the epidemic from April 2020 up to now. Mask wearing, there weren't mandates at the beginning of the outbreak, but they came in around July, and you can see when it became law to wear a mask in certain settings, then the wearing of masks shot up. So people respond to the law. If it becomes so I think that's probably the biggest deriver of people's behavior, is what the law tells you have to or don't do. Interestingly, the different colors are different age groups. The red line is actually the youngest age group, 18 to 29-year-olds. And if you look at the period before it came in place, mask wearing laws became in place, they were actually the early adopters. So actually younger individuals, younger adults were more likely to wear masks at the beginning of the outbreak. And you can see there was a steady increase in mask wearing around April, May, early June of 2020, but there was a rapid increase when it became law. Then for a year, it was law that we had to wear masks in certain settings, and you can see the levels of mask wearing was very high for a year. And then in July of last year, a year later, it no longer became a requirement to wear masks in most settings. And so you can see that mask wearing dropped. And interestingly, actually, it dropped quicker in the younger adults and dropped slower in the older adults who were more at risk. And although the older adults were less likely to wear a mask at the beginning, they became more reluctant to give them up at the end. Then over the last couple of months since Omicron, mask wearing became it became a law again for people to wear masks, and you can see a very rapid increase in mask wearing at that time. So again, when it became law, then individuals started wearing masks, and when that law was released just recently in the last couple of weeks, then mask wearing dropped again. But it hasn't dropped to nothing. So still, about 2/3 of people are still wearing a mask, despite the fact that they don't have to. So although, so I think it's a very complicated pattern, as is really what I wanted to say. People certainly respond to the law, but they also sort of, are they making assessments of their own risk and doing it that way? Well, I'm not so sure that they necessarily are. At the beginning, it was the youngest who were more likely to wear masks. At the end, yes, perhaps so. The oldest individuals, 60 plus, are most likely to carry on wearing masks. But still, so is it the law? Is it people's risk assessment or whatever? I think it's an extremely complicated pattern. And I think this is one of the biggest areas in weaknesses in models, is that trying to project forward what might happen to people's behavior. We're not there yet. And so it's very difficult for us to project forward what might happen to people's behavior when we don't have a good model of how they might respond. And I'll stop there. So just to summarize, I think there's these two routes. One is direct. I think that those sorts of information are of direct use to decision makers. Another indirect, where I think it's more difficult and it's where we're requiring quantitative data, and sometimes I think that quantitative data just isn't there and isn't not likely to be there as well in the near future, at least. Okay, I'll stop there.
Thanks, John. Super helpful and a good way to close the panel presentations. We do have questions. So we have some questions that Neha and I have drawn up, but we also have seen questions in the chat, and I see hands coming up as well. So I'm going to start with the questions in the chat, and then Julie, I see your hand up first, so you'll be the first one. So the first one is from Ruby. Is there any ongoing work on parameterizing community data and feasibility on this? So this can go to panelists or anybody else on the call if they have an answer. Any answers?
I think Ruby needs to explain that a bit better. What sort of data is she talking about?
Yeah, maybe I need to explain it a bit more. It's something that Sophie referred to, but I mean, I know about the work where you've been with social mixing data, and that's a form of community data that has been quantified and could be plugged into mathematical models. But there's a whole range of community data out there. And are there any initiatives at the moment to try and score or rank some of that community data to be able to plug it into mathematical models?
Well, maybe I'll give it a go. So when I showed you the example, so that's from the UK, but that's, that's an expensive, large-scale survey that we're running, and have been running for the last 2 years. But I don't think, yeah. I mean, are you talking more about sort of qualitative data there, Ruby, or what are you talking?
Yeah, or context data as well. So around behavior that we might be picking up in, say, household surveys, etc., or even through qualitative work about people's perceptions about what would influence their behavior, and whether we can apply a scoring method, and if there's been any validation of those scoring methods to be able to plug it into models, or whether, and so my second question was around feasibility, whether actually there have been attempts and actually it hasn't been feasible to be able to.
Yeah, I'm not aware of attempts to try and do that. I mean, obviously the sort of data that we're collecting that's directly for decision making, for modeling. And so we're asking questions specifically for that purpose, and so it has actually they're quite clunky to ask. They're not easy questions for the participants to answer, on a weekly, or actually they do it every 2 weeks. But it's quite a lot. It's a bit of a burden for people to actually go through. So other kind of more standard kind of. You're talking about sort of knowledge and attitude type surveys that might be collected in the field rapidly and things like that. No, I don't know of of things where they've been integrated into models directly. As I say, I think there's two routes. I think they're very useful as the direct routes informing decision makers that this, these are of certain issues, and that there may be some barriers and problems with implementation or whatever that the community's thrown up. So I think that it has its value in that sense. But in terms of being able to quantify some of this for use in models, I think often, it's seldom done. And there's not much work in actually trying to analyze it, as far as I'm aware anyway.
Yeah, I think just to add to that, I think I agree with John that I've not seen, there's not a kind of obvious way of, here's some qualitative data I have, and this is how I'm going to translate it into kind of a quantitative output. I think there's potentially a lot of different ways that you could do that. There would be a lot of different ways to incorporate that into models, some of which might be more successful than others. And that kind of comes back to needing to spend time on kind of evaluating and assessing these different ways of including that information to check that you're getting the most out of the data and that they're actually adding value to the kind of to the quantitative model that you want to put in place.
I don't know if we want to move on to the next question, or I can say just in terms of using data like this, often it doesn't need to be extremely well modeled for it to be usable. Sometimes just giving us an idea of tendencies is enough for us to make decisions in terms of how we respond in the field.
Thanks, John and John. I'm going to ask some people to respond maybe to some of the comments in the chat, because I also see that there's comments in the chat. Chris, I don't know if you want to say it out loud. I'm going to hop to Julia, who's had her hands up, and then see if anybody, I think Hannah and Chris also have comments in the chat. And Florian as well, sorry, yeah. Julia, go ahead.
Oh, hi. Well, it's actually right in the same vein of what John and Sophie have already been talking about with the modeling, so perfect. I don't know a lot about the modeling, but it's being involved with Henriette's work with the survey development and looking at those questions. I'm very enthusiastic about, I mean, it's exactly what we're doing, is trying to get quantitative, really high quality quantitative measures of things like perceived risk, of people's positive or negative attitude about response activities, about people's knowledge of transmission and their own behaviors. So I guess I'm, as a person who's not very knowledgeable about modeling how it works, I'm just picturing being able to take those variables and sort of put them in the models and look at them over time and see how predictive they are. So tell me like a more, like educate me a little bit more about it. I'm sure there's more to it than that. Maybe for Sophie in particular, how does that really work? Like once you have, say, survey quantitative data?
I guess it's quite a broad question, so I'll answer it quite broadly, and others please chime in if they have specific examples. But so I guess when you're collecting this data about kind of risk and attitudes and behaviors, I guess what you really want to know is how that will affect transmission. Mm-hmm. So I guess the way that you would want to try and integrate that in kind of setting up your model is to think about kind of how can I use this data about how people's kind of risk might change over time to sort of say something about how the transmission component of my model will change over time. Obviously making sure that kind of the way that fits together kind of needs to line up with the structure of the data that you have, perhaps how regularly it's updated. But that obviously comes with challenges. So I think John touched on this, that if you start including this data about behavior and you want to say what might happen kind of going forward, you then kind of have to make some assumptions about how people's behavior is going to change going into the future. So do I think that people are going to keep the same risk kind of attitudes and behaviors, or do I think that these are going to change in some way? And I think that is one of the hardest parts, is to not just think about how to incorporate it, but what assumptions I then might also need to make about what's going to happen in the future. And I think that can be where you potentially run into some problems with it being useful. Maybe John has something.
I guess I was thinking of, in this case, of having it in points in time. So you would measure it over time. So that's why I'm just sort of thinking maybe simplistically, but it would seem like if you're measuring that over time, looking at whether rates are going up and down, this is sort of what I understand what we did with Ebola in much simpler models, we were looking at the, what was it, the effective identification rate of cases, and then just seeing how that change affected the change in new cases. I think you would maybe be able to do a similar kind of black box where looking at the change in behavior over time of individuals. I don't know.
Yeah, I guess one of the other hard things, especially during the COVID pandemic, is how that kind of overlaps with a lot of other information. So you'll have people's kind of individual behavioral choices that are tied in with kind of government restrictions, and I think can be quite hard to unpick perhaps kind of the source of the behavioral changes, which is something you might be interested in. So whether it's kind of people making these choices as individuals, or making these choices because it's somehow come into law. And I mean, but obviously people's behavior is incredibly complicated. So linking that to transmission, you can maybe say something that there's some correlation, but it's hard to unpick whether that's what's causing the changes or not.
If I can add on to that, I think, oh, sorry, go ahead, Julie.
I was just going to say thank you.
Yeah, okay.
Go ahead, John.
No, I was going to say, if I can add on to that, I think a lot of this information is also moving targets. Like in John's presentation, people's attitudes towards masking changes over time. We know that people's acceptance of COVID vaccines changed over time. It's normal, and that's part of working in an epidemic, is that the goalposts change all the time, and we have to be ready for that, and we have to be able to interpret this information knowing that it may not hold from one week to the next. And I'd say the same is true for epidemiology.
Thanks, everybody.
As well, right? So you know what's happened in an epidemic based on statistics, but it doesn't necessarily tell you what's coming next. You make assumptions.
Thanks, John. Yeah, I see Sharon has her hand up. I know there's lots going on in the chat as well. So
I do. Thanks
Sharon,
a
go
lot,
ahead.
Simone. And apologize to everybody in the conversation who's already heard me bang on about this before. But my question for this particular group of speakers is, to what extent are there active discussions going on about the development of thematic indexes or scales that are based on qualitative indicators? So, for example, in various sort of WHO and UNICEF iterations over the last couple of years, I've seen the introduction of discussions around SBC scales, community engagement scales, vulnerability analysis, vulnerability assessment scales. And the methodology that applies to them is fairly similar to the methodology that applies to other kinds of indexes in psychiatric and social epidemiology, where you have sort of like, essentially qualitative variables that are being stacked together, in order to generate a number that can be integrated into a model. But because they're qualitative indicators, the subsets, like the subvariables inside the scales, can be shifted out over time, so that you aren't asking people 2 years into an Ebola outbreak if they've still heard of Ebola. You can replace it with a different kind of indicator. Is to your not like, it seems it's just I have a background training in psychiatric epidemiology as well as anthropology, and it just kind of seems to me to be this sort of continually missing piece of like translational representation of information between qualitative data and modeling that just kind of keeps getting skipped over in outbreak response. And so, since you guys are in the mix and you guys are actively working on this, I'm wondering if you can kind of speak to where indexes and scales are in the conversation, if they are at all. That's it. Thanks.
Shall I have a go at trying to answer that? For me, I think they're mostly useful background information, but they're usually not. For me as a modeler, talking about that second route by which information gets utilized, i.e. through a model, they're useful background information, but generally can't be used directly, can't be used in the model. So it might be able to help guide where you might choose some parameters perhaps, but no more than that. I mean, I'd like to make just a second more general point. Quite often, from the model's point of view, what we want is really the average behavior of the population, usually, because we don't actually subdivide the population it's usually very crude, you know, we're looking at the whole population or something. And we don't really look at heterogeneity, except maybe by age and nothing else really. I mean, honestly, that's really where we are in most instances. So we want the average behavior. Often what we get from anthropological surveys or anthropological feedback is not that, but the kind of errant behavior. Oh, there's a rumor about this, and there's some people who are concerned about that kind of thing. And I think sometimes that can be misguiding. I hear it all the time now. You know, as I showed you that mask wearing example, you know, so I know the fraction of people who are wearing a mask. It's reported to us, and I check whenever I go out and I'm, you know, go on the tube or something like that. I count how many people are wearing a mask. And at the moment, it is about 66, it's about 2/3, it's roughly that. It's roughly the same as what we've got there. But that's not what you hear people say. You hear people say, nobody's wearing a mask. Actually, they are. You're just noticing the people who are not wearing a mask and not noticing all of those people who actually are wearing a mask. And so we tend to report ourselves, you know, is the sort of unusual behavior rather than the average behavior. And I think that's one of the problems whereby, you know, trying to integrate anthropological surveys, which often report more on the, you know, aberrant behavior, the people who refuse vaccines, were actually the vast majority of people that accept vaccines and are very happy to have the vaccines. It's a failure for us to reaching them usually. Anyway, that's just a wider point, but it's one of the problems I find in trying to integrate those sorts of that kind of qualitative information into a model.
Thanks, John. Oh, big comment. Hold on, sorry. Okay, so there's chats going on. So if somebody has if we've missed a comment, please, we have time for one more question, comment, but I'm going to look at hands because there's some very good chat. Any other last comment or question? Okay, so yeah, I think there's lots of interest. So I think maybe just first of all, a really big thank you for the discussion. We will copy some of the questions in the chat and make sure that everybody has gotten a full response. And I think one of the things that Sophie and I were speaking about this yesterday or day before yesterday, I think, on just that concept of when we're looking for information, right? When we're doing a response and outbreak, we're looking for information to better respond to the outbreak. And ideally, we would be as close to where the outbreak is happening, or the multiple versions of communities and individuals who are there. And we would think about what question or what information we need to answer or respond better, and develop a methodology of data collection, be that a model or a household survey or any kind of data need to provide us the information that we need to develop that response. And I think sometimes, Sophie, what was the expression you said? If you're a hammer, everything's a nail. And so we have our particular methodology and we're like, right, okay, so this is the methodology. We know how to do this methodology. And I think one of the things that we try to do with integrated outbreak analytics is say, we need to look at services. We need to look at access, availability, use. We need to look at behavior. We need to look at models. We need to look at surveillance data. And all of that as close to where the outbreak is happening as possible, because they will vary from, you know, one neighborhood, one group, one city to another. And so really working, and that's what we hope through this working group, is working with all of you and the different experts too, and the data users and the response leaderships. So it's also great, John, to have people like you on the call, so that we can ensure that the way that we're doing the data collection and the data analysis and the modeling is really for the decision maker, and that they can use it. And so yeah, it's just super interesting to see all the discussion and all the feedback. Neha, do you have anything else that you wanted to add? And sorry, so just a reminder, this is a call that will happen. The aim is really, as we've seen in the chat, we know that there's a lot of social scientists who would like to hear more from the data users, from the modelers, of how we can make social sciences information or community collected data better and more usable. And so we really do welcome all of you and others back next week, 2 weeks, to be able to work on something that is very practical, that can help us support and coach the different actors using different pieces of data to make them more usable and used. I use that word a lot. Do you have any closing comments?
No, not so much. And I'm looking at the time and wondering if actually we want to give the floor to our panelists. And I know Raisa was meant to speak as well, but I know you've joined us now. So I wonder if we should do that, Simone.
Sure.
Yeah.
Any final comments?
If I can just say one thing, and this
Absolutely.
is really as a person, I know that with data, we really like to have clean answers about what to do. And I think it's, I mean, if you look at like the presidential election between Donald Trump and Hillary Clinton, all the statisticians had very, very clear data that Hillary Clinton would win, and she didn't. And I think we have to accept there's limitations even with really high quality data, whether it's qualitative or quantitative, and we have to deal with sort of the messiness of epidemics and the fact that we have to make decisions in uncertainty using the information that we have.
Thanks, John. Absolutely. Any other final remarks from panelists? Sophie, John, Henriette?
If I could, Simone, I think this area of particularly behavior change in response to epidemics, and whether that's you know, people changing their behavior themselves based on their risk, or because of public health response, or messaging from governments or NGOs, or whatever. I think it's a really critical area. And it's an area where we are really just in the foothills of understanding. There's, you know, there's various theoretical arguments, you know, the sort of economic epidemiology arguments, which I don't think have necessarily stood up to the test of time when you look at them. So there's sort of, or maybe they explain a small proportion of the variation, but actually generally quite a small proportion. And other things might be explaining the majority of the variation that you see through time or between individuals. So I think there's lots that we need there's so much that we need to learn in this area. And the best way to do that is to collect data systematically through as many epidemics as we possibly can, and link them with, you know, so that they also need to have the metadata there, so we know what the public health response was at that time, and that's often missing. So you might have some surveys that were done, but you don't know what exactly was in place. What were people? What public health messages had gone out by that time? What responses were in place? Were there restrictions on movements? When exactly were these put in place? You know, that tends to not be there. So we need, you know, if we can start to collect these things more systematically, then we have a hope of being able to go back and understand, you know, for past, you know, use that past experience to understand what we might expect to see if we do something similar in similar settings in the future. You know, I think that it's really the field as a whole ought to collect better data on and put the data together in a more organized way to allow this to happen. Over.
Thanks, John. And this is really what we hope to do with integrated outbreak analytics, and bringing together really, you know, events, community source data, healthcare services data, surveillance data, et cetera, including socioeconomic data, and understanding all of those different factors together. So brilliant. I'm going to let everybody have the 3 minutes on the Friday afternoon before their next call. Just a really, really big thanks to everybody again. We will follow through on the chats, and we hope to see all of you in 2 weeks' time. And the recording will be on our YouTube channel for everybody to follow up and share. Thanks so much.
Thanks a lot.
Thanks.
Thanks, Simone.
Thanks a lot. Bye-bye.
Bye.
Okay.
Thanks. Bye.
Bye, everyone.